Hello, my name is Navneet Kaur. My student ID is 221 77709. Today I'll be presenting my assessment 2 case study for nurse 2016, focusing on Mrs. Manello admitted with an embolic stroke and presents with slurred speech, left-sided weakness, and a decreased level of consciousness. In this presentation, I'll be using clinical reasoning to analyze her condition through the A to E assessment, discussing 4 priority nursing interventions and reviewing 3 medications that are part of her treatment. Moving forward to A2E assessment and clinical reasoning. For the airway, Mrs. Manello's airway is currently patent. However, due to her decreased level of consciousness, given that GCS is 12 out of 15 and slurred speech, she is at high risk of airway obstruction due to reduced protective reflexes. As per Australian Commission on Safety Quality in Healthcare 2024, we will continuously monitor for any gurgling sound, snoring, or difficulty clearing secretions and keep equipment section nearby. For the breathing, her respiratory rate is 26 breaths per minute, shallow with an SpO2 of 95% on 6 liter via Hudson mass indicates mild respiratory compromise, possibly related to fatigue or decreased conscious level. I would maintain oxygen therapy to keep saturations above 95% and observe for any asymmetrical chest movement that could suggest aspiration pneumonia, which is a common post-stroke complication as per Strong Foundation 2023. For the circulation, Mrs. Manalo's heart rate is 132 beats per minute with blood pressure 170 over 95 mmHg, showing tachycardia and hypertension. This is likely secondary to her atrial fibrillation and ongoing stress response. Her periphery, cold skin, and pitting edema in the feet indicate impaired perfusion. I would closely monitor her cardiac rhythm on telemetry and assess peripheral pulses, ensure her IV heparin infusion remains running as prescribed to reduce the risk of further emboli as suggested by American Heart Association 2021. For the disability, her GCS is given 12 out of 15 with a slurred speech and left-sided weakness, which reflects neurological impairment from the embolic stroke. The affected speech and facial droop suggest right-sided cerebral involvement. I would perform neurological observation every 30 to 60 minutes to detect any deterioration for the patient. For the exposure, she is afebrile with no wounds or bleeding, and her VGL is within normal limits at 5.5 mmol per liter. Maintaining her body temperature and blood sugar level is vital to prevent any secondary neuronal injury. Her IV saline and fluid heart means 20 milliliter per hour are appropriate for hydration and medication administration. Overall, from this A to E assessment, my priority concerns are airway protection, cerebral perfusion, and prevention of further thromboembolic events. Coming to high priority nursing intervention and rationales, number one, maintaining airway and oxygen level. I would position Mrs. Manello in a semi-fowler position to promote airway patency and ease of breathing. As per Stroke Foundation 2023, administer oxygen via Hudson mask as prescribed to maintain SpO2 more than 95% as hypoxia can worsen cerebral damage. Keep suction equipment available in case of secretion buildup. Number two, for continuous neurological and vital signs monitoring, I will check her neurological status, vital signs regularly. A drop of 2 or more points in GCS will trigger immediate action. According to Australian Commission on Safety Quality in Health and Care, early detection of changes allows rapid intervention, reducing the risk of complication and long-term damage. Number third priority is manage blood pressure and cardiac monitoring. Monitoring her heart rhythm for atrial fibrillation and maintaining BP within targeted range. Sudden drops in BP could worsen cerebral perfusion, while uncontrolled hypertension increases the risk of hemorrhagic transformation as per American Heart Association and American Stroke Association 2021. Number four, prevent aspiration and promote safe swallowing. Keep the patient ill by mouth until a speech pathologist assesses swallowing ability. If clear, provide texture modified diet and supervised meals. As per NSW Health, dysphagia is a common after stroke and can lead to aspiration pneumonia. Early assessment and safe feeding practices reduce respiratory complication and support recovery. Coming forward to medication considerations, I will now discuss three key medications used in Mrs. Manella's management: IV alteplase, IV heparin, and metoprolol, focusing on nursing assessments, administrations, and side effects. For IV alteplase, for the assessment before administering, confirm the onset of stroke symptoms and exclude hemorrhage via CT scan. Baseline observations, coagulation profile, and blood glucose must be checked before giving. For the administration, alteplase is administered as an IV bolus followed by an infusion over 1 hour under specialist supervision. For the side effects, the major risk is intracranial or systemic bleeding. Therefore, post administration, I would closely monitor GCS blood pressure and for signs of hemorrhage such as headache or vomiting or bruising as suggested by Stroke Foundation. Number two, heparin IV infusion. For the assessment, we'll check baseline APTT platelet count and signs of active bleeding before initiation. For administration, we'll administer via infusion pump to ensure accurate dosing with regular APTT monitoring within a therapeutic range. For the side effects of this, monitor for bleeding, heparin-induced thrombocytopenia, and bruising at injection site. Any bleeding might occur. Stop infusion and notify the medical officer immediately as suggested by MIMS 2024. For our third medication, metoprolol, for the assessment, we'll assess heart rate, BP, and signs of heart failure before each dose. For administration, we'll administer this orally with food to reduce gastric irritation. For the side effects, we'll watch for bradycardia, hypotension, dizziness, and fatigue, as it can mask hypoglycemia symptoms. Glucose monitoring is important in diabetic patients, as suggested by therapeutic guidelines. Together, these medications aim to restore perfusion, prevent further clot formation, and stabilize cardiac rhythm, forming the pharmacological foundation of embolic stroke management. And for the conclusion, in summary, Mrs. Teresa Manello's embolic stroke requires rapid structured assessment and critical nursing actions focused on airway protection, neurological stability, and prevention of complications. By applying the A to E framework, integrating evidence based interventions, we can prioritize timely care and improve patient outcomes. Ongoing collaboration with the multidisciplinary stroke team, vigilant monitoring, and patient centered communication remain vital components of high quality stroke nursing practice. At last, I have included my referencing list with 6 references for the content I have used in this oral presentation. Thank you.